the viewers and Kenyans who have followed up the position of KMPDU on this matter, SHA, is that from the word go, we said that SHA, as was conceived, had some problems. And sometimes it's very disappointing when I see the politicians and the MPs tweeting like all of us or doing press conferences like all of us. Because they are the people who made the law. KMPDU gave a 25-page document of why SHA, as was conceived, was going to be problematic. And I remember the former CS boasting how not even a comma was changed. Yeah? And so right now, whatever is happening is that the wind that is exposing the chicken's tail is blowing from behind. What do I mean by that? That there are certain principles of social insurance that were ignored when SHA was being conceived. One of them is that, did you ever consider issue around the adverse selection? When you tell people that you can fall sick, then register and go get treated. It's like buying a car, you don't insure it, then when you knock it, then you are told you can now pay for the insurance. Even if you need to pay 40,000 and the repairs is 200,000, going to be a loss. The same loss that Lishenga talked about, that the claims, the loss ratio is too high. Number two is about the problem of the Kenyan people, called the moral hazard, that since you know you have an insurance cover, you will go to hospital for anything and everything. And at the same time, the healthcare provider knows that you have a cover. Then if they just removed a toenail, they'll give you a very big surgical name and claim higher. The problem that started the SHA is that us as Kenyans ourselves, we are very, very corrupt people. We have not protected the SHA enough. And my brother and my colleague, Dr. Lishenga, will try to defend the whole fraud thing. The whole fraud is a reality. And in fact, it is worse than in NHIF days. Why do I say so? Because in NHIF days, only private hospitals were desperately looking for how to run their costs. These guys have to pay employees, buy drugs, and all these things. But right now, one of the 4 laws that were passed last year was a facility improvement fund, where money is collected at a facility is wired back to the facility. It's a good thing. But the challenge with it is that now even public hospitals are now engaging the fraud because they want the money to come to them. I know of a doctor, colleague who told me that he has a private sector background and he has learned to ensure that any given time the wards are full to ensure that they get maximal SHA reimbursements and claims. So SHA is there enough for our needs, but can never be there enough for our greeds. And why do we have to say this? The whole idea when they were forming SHA, some people went and borrowed the Thailand model, which is perfect. But what they forgot that 80% of Thais go to public hospitals, where in the public hospitals, the workers are being paid by the exchequer. So these hospitals don't have to worry so much about paying the salaries. Vis-a-vis somebody who opens a clinic for business. Yeah. Right now, almost 60% of Kenyans go to private hospitals. These guys are in business. So when you don't pay them and delay their claims, our members in the union go without salaries. They can't pay rent. People are getting fired. Hospitals are getting closed because nobody opens a hospital because they love Kenyans. They're in business. And when you're in business, you also have to add certain charges. The drug that would cost 100 shillings, they'll put maybe 500 shillings to put markup. And also the uncertainty and the unpredictability of the payment makes you want to have some buffer. And finally, some of these hospitals, also because of that unpredictability, once you insist on cash payment, they'll tell you, the system is down. This is not working. The other day, I had a relative go to JTRH in Kisumu, and go to the CT scan room. It's like a marketplace. Everybody is sitting waiting for the system to open up and work and serve them. How come this system works when you're supposed to be paying for the premium, but when it comes for it to pay for you, all of a sudden this system is crashing? Yeah? And one thing I want to tell the government, that as long as the numbers of patients in Kenya, that for you to get proper treatment, you have to go to a private facility. SHA will never be sustainable. We have been told about the numbers, and the numbers are just a tip of the iceberg. We must find ways of driving the numbers back to public hospitals, where at least you don't have to worry about salaries of employees, where KMSA can give you drugs and wait for 3 months before you pay for those drugs. But expecting the private sector people, and people normally ask as I finish, that is SHA working or not? And that's a question that I keep on saying, that somebody who says that SHA is working is not wrong. Somebody who says that SHA is not working, they're both not wrong. Why? Because if you go to a hospital in outpatient and you pay cash when you have been told that it is free, to you it's not working. When you go and you're admitted and SHA pays your inpatient admission and it's served, to you it's working. So we have to ask ourselves that this 80% of Kenyans who go to outpatient and don't get the cover, what can we do to mitigate their issues? Because so far their voices are louder than the 20% who are being admitted and are being served.